Welcome to my ACLS prep course series. So these are a series of videos, topics that you can use in preparation for your ACLS class. So this would help you gain the foundation or the knowledge that you would need to pass your ACLS course. Just a quick disclaimer, this is not an official AHA content, but this is based on 2020 AHA guidelines. So now for today, we'll be talking about basic arrhythmia. So this course, it's designed to provide an introduction to the basic concepts and principles of cardiac arrhythmias. You will learn how to identify and interpret common arrhythmias using ECG and how to apply appropriate treatment strategies based on the underlying causes and clinical scenarios. So just a quick review, the heart's conduction system. In my actual class, I would ask someone to describe the pathway of the electrical conduction system of a heart. But since this is a video, we're not going to be able to do that. So our heart has its own natural pacemaker. So electrical impulse, it starts from the sinus node right here. So it travels all the way through the internodal pathway, and then the impulse gets transmitted to the AV node or the atrioventricular node, and it travels through the left and right bundle branches right here. So that's through the internal wall of your ventricles, and then it goes through the Purkinje system, going through the outside wall of your ventricle and going back to the sinus node. So the cycle keeps going on and on and on and on. Later on, we'll discuss a few more topics for AV block. You would see that there's a blockage on this area. The transmittal of the electrical impulse from sinus node to AV node, there's a bit of a delay. So you would see that also on the ECG. So you would notice that the sinus node, it fires from 60 to 100 beats per minute. That is your heart's normal heart rate. So our heart rate, it should be within 60 to 100 beats per minute. So if the impulse starts from sinus node, you would see that the configuration would be complete. There's a P, there's a QRS, and there's a T. So we call that sinus rhythm. If there's no delay, the configuration is complete, if the rate is within 60 to 100, and then if the rhythm is regular, then that's a normal sinus rhythm. So sinus node fires 60 to 100 beats per minute, and then AV node 40 to 60, and then Purkinje system, it's 30 to 40. You would notice that there is a delay. The sinus node fires faster than the AV node and then the Purkinje system. That's because your heart needs to maintain this process wherein the atrium should refill with blood first, and then it empties out the blood to the ventricles and it pumps it out. So imagine if all of your chambers, your 4 chambers, contracts all at the same time without any delay. So there would be no refilling, there would be no pumping. So if that happens, if your heart is pumping all at the same time, that could be somehow, it's like a VFib. It's gonna look like that, or VTAC. Okay, all right. So the anatomy of the ECG. So the ECG, it is a representation of your heart's electrical activity. So if you see a P wave right here, that means it's your atrial activity. So as the impulse travels from the sinus node to AV node, so this section right here, that produces your P wave. And then there's what we call the PR segment. It starts on the first part of the P wave, and then the first part of the QRS complex. So that area right there, it's what we call the PR interval or the PR segment. So this is important. Take note of this, the PRS segment, when identifying heart blocks. And then the QRS here, QRS, that is your QRS. That is your ventricular contraction. So as your ventricle contracts, it produces this complex or this wave. And then there's the ST segment. Then as your heart repolarize or recoils, that's what you call your T wave. Okay, so now you would see this is a normal sinus rhythm. The electrical impulse, it's smooth, no delay. It starts from the sinus node going to the AV node through the internodal pathway, and then left and right bundle, and then the Purkinje system, and it goes back to the AV sinus node. All right, so on an ECG, just a quick refresher for this. That small box right there that you're seeing, let's say this box here, those boxes, there's 5 small boxes. That is equivalent to 0.04 seconds. So one big box like this, that is equivalent to 0.20 seconds, which is your normal PR interval. If it goes longer than 0.20 seconds, so that could mean that your patient is having an AV block. All right, so you would know this here. This is the P, this is the Q, R, S, and then this is T. Your PR segment, that is within one box. So that means it is normal. Okay, PR interval, it should only be like 0.12 to 0.20 milliseconds. And then QRS complex, a normal narrow QRS complex, it should be less than 0.12 seconds or 3 boxes there. So you can reference with this picture like the normal measurement of each wave there. Okay, most of the ECG, they put, it puts the heart rate of the patient, but just in case that you get an ECG strip without a heart rate on it, this is a quick way to estimate the heart rate of a patient. So what you need to do is you need to pick a complex that falls on a heavy line. So this complex here, it falls into this heavy line. And then you count the number of the lines, heavy lines, up to the next QRS complex. So on this case, on this case, so that's 1, this is 2, 3, 4. So approximately your ECG's rhythm or your patient's rhythm is 75 beats per minute. So how do we get this number? So what you need to do is, after you count the line, you divide it to 300, or 300 divided by 4. So that would give you 75 beats per minute. Okay. If you are analyzing an ECG, these are the few questions that you need to ask to yourself to identify what type of arrhythmia is this or what type of ECG is this. You need to check the rate. Is the rate normal? So once we say normal, it should be 60 to 100 beats per minute. Anything lower than that, that's considered as brady. And if it goes higher than that, that's tachycardic rhythm or tachyarrhythmia. All right, and then next would be the rhythm. You need to look at the rhythm. Is it regular or irregular? To say that it's regular, the R to R segment should measure the same. There should be no drop beat. The measurement should always be the same. So let's say for this ECG, okay, this is the R, this is the R. So the measurement between this and this and this and this should always be the same. So you would notice in second degree heart block type 2 or type 1, there would be a QRS missing. Imagine this is the QRS missing. So the measurement of this R to this R, it's longer than this 2. Okay, so make sure that the distance of R to another R are the same. So you need to identify if it's regular or irregular. And then the next thing that you need to look for, are there P waves on that ECG? So each P wave, there should be one P wave every one QRS. So there should be a 1:1 conduction. So later I'll discuss further on the heart blocks. You would notice that there's 2 P wave on 1 QRS. So it's not a 1:1 conduction. And then you also want to have a look on the QRS complex. The QRS, is it normal or is it wide? If it's wide, think of monomorphic ventricular tachycardia or polymorphic ventricular tachycardia. And then this one, I only use this for face-to-face lecture. We do an activity wherein the student guesses the ECG presented behind them, and then they need to ask this question to identify which ECG they're looking at or that they're guessing. Okay, for normal sinus rhythm, the rate should be 60 to 100. The rhythm should be regular. P waves should be present, and it should be 1:1. So 1 P and then 1 QRS. So this here, that should always be the case throughout the entire ECG rhythm. No need to do anything, it's a normal sinus rhythm. If the rate goes slower, same configuration, and it's regular, there's a P wave present there, that's a sinus bradycardia. If it goes faster, then that's a sinus tachycardia. I'm just skipping on this one because this is a heart block. So disregard this ECG strip. I wasn't able to edit this, but that's a heart block. Okay. Now, as we go on deeper on this topic, our arrhythmias, it would be divided into 3 groups. So the bradyarrhythmias, tachyarrhythmias, and then the shockable rhythms and non-shockable rhythms. So I think you would need to memorize at least 12 ECG rhythm. So let's go for the first part. This is the bradyarrhythmias. These are abnormal heart rhythms that are too slow. This can cause symptoms such as dizziness, fatigue, or fainting. This can be caused by various factors such as aging, heart disease, medication, or even electrolyte imbalances. So bradyarrhythmias can be treated with medications, pacemakers, or other devices. So the first one on the list is the sinus brady. And then after that, that's all your heart blocks. First degree AV block, second degree AV block type 1, and second degree AV block type 2, and then complete heart block or the third degree AV block. All right. So sinus brady, we're gonna leave it. We're done with it. It's a slow rhythm. There's a complete configuration. There's P, Q, R, S, and T. PR segment, it's normal. It's less than 0.20 seconds, but it's just too slow. Okay, now we'll proceed with first degree AV block. So first degree AV block, it is a type of heart rhythm disorder in which the electrical signal from the atria, from here, is delayed going to the ventricles. So this is the AV node, this is the SA node. So there's a delay going to this area right here. So it looks like there's an underlying sinus rhythm. There's one P wave every QRS. So one P wave every QRS. One P wave, one QRS. One P wave, one QRS. The only problem with this one is the PR segment. If you look at the PR segment, so from here to here, that is approximately 2 boxes. And then this one here up to here, that's 2 boxes as well. And then this one up to this one, approximately 2 boxes. So it is consistent that in every QRS complex there's a P, but the distance of the P to QRS, it's consistently prolonged. 2 boxes, 2 boxes, 2 boxes. So we know that the transmission of the electrical impulse from the SA node, it's getting delayed going to the AV node. Okay, like that. See, you can see that there's a pause right there. Instead of going whoop, like that, it pauses on this section right here. All right. Now, second degree AV block type 1 and then second degree AV block type 2. So second degree AV block type 1, we also call it Mobitz type 1 or the Wenckebach phenomenon. So for you to remember this easily, think about of the word W, the word warning. So you have a warning sign. What do I mean by warning sign? So you know that at one point your QRS would go out missing. So the problem here is your AV nodal cell is malfunctioning and it tends to progressively fatigue until they fail to conduct an impulse. Okay, so P wave fails periodically to conduct QRS. Okay, so another characteristic of this is continuously prolonging PR segment. So let's go back to this ECG strip. So the PR segment here, it looks normal to me, less than 1 box or almost 1 box. Now on the next one, it became 1.5 box. And then the last one, it's 3 boxes, approximately 3 boxes. So from 1, 2, 3, there's another P wave. Now the QRS is missing. There should be 1 QRS here, but now it's missing. Now it goes back again to 1 box, 2 boxes, 3 boxes. So this characteristic, this gives you a warning that the QRS complex would go out missing. So it's continuously prolonging the distance of the PR segment. Okay. Now with the second degree AV block type 2, this is more serious than the other one. The thing there, it's like it's normal. Initially you would see this. There's a P, there's a QRS, and there's a T. There's a P, there's a QRS, and there's a T. If you look at this, this actually looks a normal ECG rhythm. But as you move along, now this is a P, the QRS is missing. There's no warning that your QRS would go out missing. Okay, there's no prolongation on this one. So second degree AV block type 2, there's a dropped QRS complex. The PR segment could be normal, but then you have a missing QRS. Okay. Now this is a third degree AV block or complete heart block. What's happening here is that your atrium, this section here, and then your ventricle, they are totally not talking to each other. Imagine that there is a complete block in between the two of them. So what's the tendency of your heart to do? Like what's the heart gonna do? In a normal setting or a normal ECG, your ventricles would wait for your atrium to finish. It would wait for the signal from the sinus node going to the AV node before it fires or before it contracts. Now that they cannot see each other, they cannot talk to each other because there's a block right there, your atrium would work on its own. It would create its own pace, and then the ventricle would create its own pace as well. So the PR segment now would be unrelated to each other. So again, remember, PR segment should be at least 0.20. Within 0.20 seconds or 1 box. So if you look at this, there's no pattern at all. This measures like 3 boxes or 0.60 seconds. So there's 3 boxes here. This, we don't know if this is actually a T wave, but looks like an atrial activity. Here there's 1 box. And then here there's 1, 2, 3, 4. 4 boxes. And then here there's 2 boxes. So you can see there's no pattern at all. And then this wave there that you're seeing with the arrow, those are your atrial activity. Sometimes it could lead to more atrial activity than the QRS complex or the ventricular activity. So if you measure this, and then you measure this, and you measure this, these are regular. And then if you measure this, and this, and this, these are also regular. So third degree AV block, ventricular escape. It's the same thing, but you would see the characteristic of this like a shark's fin wave right there. But you would see again this. Sorry for the arrows, it's not accurate. But if you measure this and this and this, these are all P wave activities. It's regular. It measures the same all throughout. And then your P wave here, your QRS complex here, and then here, and then here, they all measure the same. So it's a regular rhythm with unrelated P to QRS complex ratio. So if you want to have a look and then compare, like this is the sinus rhythm, smooth transition of electrical impulse. Sinus brady, it's slow. First degree heart block, consistent delay from sinus node to AV node. There's a pause right there, but there's no QRS drop. Still, the configuration is complete. Okay, comparing second degree AV block to your normal sinus rhythm. For second degree AV block, the PR segment would be prolonged or prolonging, and then there would be a drop beat because your AV node, it gets tired on transmitting the electrical impulses to generate the QRS. So you would have a skip QRS. In second degree AV block, the transmission is normal, but at one point, suddenly, there would be no QRS complex. Okay. So, okay, what rhythm is this one? How about this one? Let's analyze this. Okay, the first ECG strip. Is it fast or is it slow? So let's have a look. If this is the heavy line, so 1, 2, 3, 4, 5, 6, 7, 8. Okay, let's compute that. So 300 divided by 8. So that's approximately like 37.5 or 40 beats per minute. So we know that this is a bradycardic rhythm. How about the rate, the rhythm? Is it regular or irregular? So just by looking at it, the QRS are all the same measurement. So this is regular. How about the PR segment? 1 box right there. 1 box. 1 box. Normal. So this is a sinus bradycardia. And then if we go on the next one, again, let's check for the configuration. There is a P, check. There's a QRS, check. There's a T. All the way, it's complete. Is it fast or is it slow? Let's check 300. 1, 2, 3, 4, 5. So 300 divided by 5, it's 60. Borderline bradycardic. Okay, so still, let's move on. Let's go on. So the QRS complex, is it regular? It is regular. Now we check for the PR segment. This is the PR segment here. So it's almost 2 boxes. We know that there is a delay. So this is a type of heart block. Now, what we need to figure out is the delay prolonging? Is there a drop beat or is the delay consistent? Is it 1:1? Okay, so 1P, 1 QRS, 1P, 1 QRS, 1P, 1 QRS. So what is the 1? Now, 2 boxes, 2 boxes, 2 boxes, 2 boxes. It's a consistent, regular prolonging delay. So that is your first degree heart block. Okay. Now, the next rhythm, P, QRS, T. P, QRS, T. P, QRS, T. P. Where is the QRS? So there is a drop beat. So another P, QRS, T. P, QRS, T. Okay. Configuration, you have a P, you have a QRS, and you have a T, but there's a drop beat at one point. Is it regular or irregular? It is irregular because the measurement of this is longer than this. Okay. Now the PR segment, this is normal, 1 box, almost 2 boxes. Now this is 3 boxes. So we can see the pattern. 1, 2, 3. It's constantly prolonging and then there's a drop beat. We have a warning sign. And then let's go and check for the ratio. Is it 1:1 P to QRS? It's not 1:1 anymore because if you look at this, This is 1P. This is another P. So that's 2:1 QRS. So you have a warning sign constantly prolonging. This is your, and then there's a drop beat. This is your second degree heart block type 1 or wake-back phenomenon or Mobitz type 1. On the other ECG rhythm, it's normal. The PR segment, it's normal. There's a P, there's a QRS, and there's a T. There's a P, there's a QRS, and there's a T. There's another P, there's a QRS, another T. There's a P, but there's no QRS here. Now this is another P, and that's a QRS and a T. So again, it's not a 1:1 conduction, no warning sign, but there's a drop beat. So that is your second degree heart block type 2. Okay, P, QRS, that's a P, there's a QRS, and there's a T. There's a P, QRS, and there's a T. It's too short for us to tell if it's regular or irregular, but by the looks of it, it looks regular. We cannot find the pattern. There's only 2 rhythms that we can see. But you can see this characteristic. And then if you measure all of the P activity, boom, 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 it's all the same. So it means, again, your atrium, it's working on its own. It has its own pace. And then the QRS also has its own pace. Okay, on the next one, it's same thing. This one, it's much better. We can see actually the PR segment, what's the changes or what's the measurement of the PR segment. Okay, let's count this. 1 box, 1, 2, 3, 4. 4 boxes, 2 boxes. So 1, 4, and 2. No pattern. It's not progressively increasing. And then if you measure the atrial activity, boom, 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 it's regular. Your atrium, it's pumping on its own. And then your ventricular activity, here, 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 it's also regular. It's also working on its own pace. So this is your complete heart block. So these are the rhythms that you need to memorize or at least learn for the bradyarrhythmias. If the patient is stable, monitor the patient, do nothing. If you need to do further assessment, then proceed and treat underlying cause if needed. If the patient is unstable, you consider giving atropine 1 milligram every 3 to 5 minutes, max dose of 3 milligrams. And or you can also start TCP or transcutaneous pacing. We will use our LifePak 15 or the Zoll unit in the training center to simulate transcutaneous pacing. And if it's not working, now you can proceed with dopamine or epinephrine infusion. So another thing that you can do to memorize this, think of it all trained dogs eat. So think of this for you to, memorize this: atropine, transcutaneous pacing, dopamine, and epinephrine. But now, the big question is, how would you know if the patient is unstable? So part of the training is for you to learn how to use the algorithms. Most or all of our ERs in our clinics, we have the AHA posters. It's there for a reason. It's not just there for decorative purposes. Let me just have a look if we have something here. So it's not in this slide. On the next one, you would notice on the algorithm, bradycardic algorithm and the tachycardic algorithm, there's a red section right there. I want you to go and check your books or your resources. Go and find the red section right there. There are few questions there. One of those, is there an altered mental status? Does the patient have hypotension? Does the patient have ischemic chest pain? Those questions there, that's your guide to see if the patient is stable or unstable. So for hypotension, if the patient's blood pressure, it's, let's say, 100/70, is the patient stable or unstable? Okay, so the patient is stable, hemodynamically stable for this case. So our guidelines for that is, for the blood pressure to consider it's hemodynamically stable, it should be at least 90 millimeter mercury systolic. If the systolic BP is 90 and above, then that's okay, that's fine. All right. Let's say a patient presented and the patient is complaining of chest pain. He collapsed. Let's say the patient is 60-year-old male patient and he collapsed. And then he was brought into the clinic. So the main concern is chest pain. Just by the fact that the patient is complaining of chest pain, that makes the patient unstable at that point. Okay. All right. So sinus brady, first degree heart block, same scenario. If the patient is stable, if you look at your algorithm again, like what I mentioned, do nothing, monitor the patient. If the patient is unstable, you need to proceed with your all trained dogs eat, or ATDE, atropine, transcutaneous pacing, dopamine infusion, or epinephrine infusion. If your patient presents with second degree heart block type 1 and second degree heart block type 2, if the patient is stable, don't do anything. If the patient is unstable, same thing, all trained dogs eat. Atropine 1 milligram every 3 to 5 minutes, max dose of 3 milligrams. Transcutaneous pacing, dopamine, and epinephrine. Okay, so this right here, if the patient is having a Mobitz type 2, you do not rely on atropine. So most likely your atropine would not work. So you can proceed with your transcutaneous pacing or dopamine infusion or epinephrine infusion. If your patient has a complete heart block, you skip your atropine. You proceed with your TCP, dopamine infusion, or epinephrine infusion. Okay, so avoid relying on atropine in type 2 second degree and third degree AV block. Most likely it's not gonna work. So if you've done ACLS before, the previous guidelines, we give atropine, the dosing is 0.5 milligram IV. But throughout their study, they found out that 0.5 milligram may further slow down the heart rate. So that's the case, they increased it to 1 milligram per dose. So you should use atropine cautiously in the presence of acute coronary ischemia or myocardial infarction, because it may worsen the ischemia or increase the infarct size. If bradycardia is not the symptoms, is not causing the symptoms, TCP may be ineffective despite a capture as well. Okay, so you need to investigate. You need to find out what's happening to this patient. Okay. What if, let's say, the low blood pressure of the patient, it's not coming from the bradycardia, if there's something else, something is wrong. Even if you correct the patient's heart rate with a TCP, you would see that the BP is not going up. let's say if the patient is dehydrated or the patient is in a hypovolemic shock, even if you pump the heart faster but the volume is not there, you're not going to be able to put the BP up. Okay, now let's move on to the rhythms for tachycardia. So one of the rhythm that's under the tachycardia algorithm, it's the atrial fibrillation. So you would see that your atrial activity here, it's chaotic. It's pumping uncontrollably. So your atrium is quivering. If you visualize this, if your atrium is doing this, there would be no blood refilling this area to pump down to the ventricles. Okay, so your electrical impulse, it's messed up. So the treatment for this, if the patient is unstable, you need to cardiovert the patient. You need to correct the electrical impulse. So you would see that there is a fibrillatory rhythm with every QRS. Atrial fibrillation, there is an irregular rhythm. You see, this is longer than this one and this one. It's different. Okay, so the next would be atrial flutter. Comparing to atrial fibrillation, it's more organized compared to atrial fibrillation, but still your atrial activity, it's going too fast. So it's not refilling the atrium properly. So that can cause issues also for your patient. Okay, so it's well known for its characteristic having this sawtooth characteristic. It looks like a sawtooth. So your atrium, it's pumping too fast. Sometimes it could reach up to 400 compressions per minute. Okay, you only see a flutter wave on this one. So now your supraventricular tachycardia, the rhythm keeps on going back and forth, repeating itself here on the AV node. So your ventricle, it's pumping too fast. So you would see that the ECG would look like this. There's no time to recuperate. So it's like it's overlapping. You would see this. We don't know if this is a P for this QRS or is this a T for this QRS. So it's overlapping. But there should be P waves there. It's inverted in lead 2, 3, and AVF. You will be able to see that as well. Okay. Alright, so now the next one would be ventricular tachycardia. So it is like this. Your ventricle, it's pumping too fast and too hard, therefore obscuring the P wave. So you cannot see the P wave. And this is the monomorphic ventricular tachycardia. It looks the same at all times. So mono means one, morphic, it's the appearance. So there's one appearance for all this rhythm all throughout the ECG. Polymorphic, that looks like that. So it's quite chaotic, no pattern. This is also a serious ECG. So the treatment for this is unsynchronized high energy shock, or like you need to defibrillate the patient, not cardioversion. So we cannot do cardioversion because for cardioversion, it picks up your R on your QRS. But since it is everywhere, your rhythm is everywhere, it cannot pick up the R on the peak of the QRS. So it's not gonna work. That's why you need to do unsynchronized cardioversion, or you can also give magnesium if there is a baseline QT prolongation. All right, now this is what's happening for a patient with ventricular fibrillation. Your heart is pumping like that. It's not actually pumping, it's quivering. So it's not able to pump out the blood that's needed to sustain life. So for a ventricular fibrillation, our treatment is to defibrillate. We need to defibrillate this patient. Okay, so we need to shock the patient. So for LifePak 15, the recommendation, it starts with 150, 200. It starts with 200, and then 300, and 360. Okay. So same thing, ventricular fibrillation, chaotic line. No proper ventricular or atrial activity on this one. So treatment would be immediate shock. So everyone knows this, asystole, flat line. This, we don't shock the patient. It's just in the movies that we see like that, and then they would shock the patient and the patient would come back. No, it's for theatrical purposes only. So we only shock the patient if the rhythm is something like this. Okay, so your treatment for this is CPR and epi. PEA, there is an organized rhythm like this, but once you check the patient's pulse, there's no pulse. It's just electrical activity, not generating cardiac activity. Okay, so that's just a quick review for ECG. So this is important. You need to have a good foundation on this arrhythmias, because if you cannot identify the ECG at the first part early on your scenario, you would not know what to do. You would not know on how to proceed on the case that's going to be presented to you. Okay, so on my other video, I discussed about this vomit for systematic approach. So if you think of this like V, it stands for visualize vital signs and verbalize. So this V's here, these are what you do if you do your assessment. So you visualize, you go and have a look at the patient. Does the patient look weak? Is the patient diaphoretic, or is the patient unconscious? Those things. And then vital signs, you check for the A, B, C, D, and E. And then if time permits, then you can ask more questions. You use your sample history taking. Check for the signs and symptoms, allergies, medical history, medication, past medical history, last meal intake, and event that led to this case. If your patient is also having is complaining of pain, it's much better to ask the patient, use the OPQRST pain assessment. O, onset, P, provoking factors, Q, quality, R, radiation, S, severity, and then T, it's time or treatment. So did the patient take any medication for that? So those things. So this applies to this. So you assess for the appropriateness for the clinical condition. And then O is oxygen, M is monitor, then I is IV. So this would serve as a guide for you. So if you check O, if hypoxemic, then give oxygen. Monitor, you can attach the cardiac monitor to identify the rhythm. You can check for the blood pressure and then oximetry. And then 12-lead ECG, that falls under your M right here. And then I, you insert an IV line, maintain an IV access. And then T would be that treatment. You need to identify if the patient is stable or unstable. So it's the same with the bradycardic algorithm. So if the patient is unstable, you would check this red section right here that I'm talking about. If the patient is complaining of chest pain, and then the patient is hypotensive, and then now the patient is unstable, your first treatment for tachycardia algorithm would be synchronized cardioversion. You consider sedation if the patient, because it could be painful if the patient is conscious. If it's a regular narrow complex, you can now consider adenosine. If it did not work, you can consider treating underlying cause or increasing the energy level for this case, or add antiarrhythmic drug or seek for expert consultation. If the patient is stable or none of this is present to your patient, you go down to this section. Is it wide or is it narrow? If it's wide, then this would be your treatment. If it's narrow, this would be your treatment right here. But be careful on doing vagal maneuver, especially for elderly people. You might dislodge something. Let's say if you're gonna do the carotid massage, you might dislodge some plaques or blood clot, and then it can go through to the patient's brain and cause harm, or can cause stroke to this patient. All right. Okay, that's it. So most of the treatment, it's always QRS. It's always cardioversion, sedate and cardiovert. Okay, on this new algorithm or new update that AHA released, they put back lidocaine on the list. If you don't have amiodarone, you can use lidocaine as an alternative. So the dosing would be, for cardiac arrest patient, would be 1 to 1.5 milligram per kilogram. And the next dose, if needed, would be half of the dose that you've given to the patient. Okay. Just critical concept for tachycardia, do not cardiovert a patient who has a sinus rhythm. So you would notice on the bradycardic algorithm, they have included sinus bradycardia. But for tachycardic algorithm, sinus tachy, it's not included. I can go to the clinic and present with a heart rate of 120. Let's say I run to the clinic, I'm having chest pain. My heart rate could not be from, my chest pain could not be from my increased heart rate. I can have, 3 coffees, and then I showed up to the clinic, I'm complaining of chest pain. See, if it's a sinus rhythm, it's tachycardic, it's not included on the tachycardia algorithm. You need to correct and treat the underlying cause. Okay, so arrhythmias with a polymorphic QRS will not usually permit synchronization. So that's why you need to defibrillate. That's what I mentioned earlier. If possible, you establish IV access before cardioversion to administer sedation. All right, so that's it. For cardiac arrest, so we have two, the ventricular fibrillation and then the monomorphic or the pulseless ventricular tachycardia. So our medication would be epinephrine 1 milligram every 3 to 5 minutes, or, and then after that, give 300 milligrams of amiodarone, and the second dose, if needed, would be 150, or now you can consider lidocaine. If there is a non-shockable rhythm such as a systole or PEA, and then the only medication that you would give is epinephrine. CPR, then epi. Take note of this, it's 1:10,000. You don't push 1 ml of epinephrine to a patient. You need to dilute the epinephrine to a 9 ml NSS to make a 1:10,000. All right, that's it. Thank you.